Welcome to the Hospital Medicine Unplugged podcast. Today we are undertaking a really critical deep dive into one of the most persistent and frankly dangerous ethical dilemmas we face in acute care, and that's the use of restraints. It's a topic where the stated intent, protecting patient safety, it so often clashes dramatically with the actual outcome. And the literature shows us that outcome frequently involves increased harm, both physical and psychological. Our goal today is to synthesize a pretty wide range of literature. We're drawing from psychiatric guidelines, critical care protocols, and general medicine studies. We want to really unpack what current best practice looks like and, maybe more importantly, why we still struggle so much to meet it.
It's such a necessary conversation because when you look at the data, you immediately confront this fundamental paradox. Restraints, whether they're physical or what we call chemical, they're almost always brought in during moments of intense crisis. They're intended to be the ultimate protective measure, but they fundamentally restrict a patient's liberty and their autonomy. And our sources all highlight that because this intervention is so intrusive, the legal and ethical bar for justifying it, well, it has to be exceptionally high. Higher, I think, than many facilities routinely meet.
That's the core issue, isn't it? The immediate perception that restraint equals safety just seems to override the rigorous assessment that's required. Okay, so let's unpack this with some foundational definitions, because restraints can cover a huge territory in the hospital. When we talk specifically about physical restraints, what exactly are we talking about?
Well, the definition is any manual method or any mechanical device or equipment that specifically and intentionally reduces a patient's ability to move their arms, legs, body, or head freely. The key word there is freely.
And that definition is crucial for compliance.
It absolutely is. It includes the devices we all immediately think of, like the standard wrist and ankle restraints. Those can be cloth or, the more restrictive leather ones. It also covers things like vests, trunk belts for the upper torso, and even pediatric devices like papoose boards during procedures.
Right.
But importantly, the definition also extends to things that can look pretty innocuous, like bed rails. We have to include bed rails when they are used specifically to restrict movement, not just for positioning or to help the patient move. If the intent is to physically stop the patient from getting out of bed, it's a restraint, and it requires the exact same regulatory oversight.
The intent really is everything. Okay, shifting gears a bit to chemical restraints. This area is definitely fraught with definitional difficulty, and in my experience, it's often where clinicians are the least compliant. I think it's because they just see it as administering medication, not as a form of restriction. Our sources define them as medications used primarily to control behavior or restrict freedom of movement, and that's rather than as a standard treatment for an underlying condition.
Exactly. And this is where the American Psychiatric Association, the APA, has strongly advocated for a change in how we frame this. And we should really adhere to it. They emphasize that chemical restraint is a poorly defined and, frankly, an inherently punitive term. They strongly recommend a different description: pharmacological treatment of agitation.
That's a huge shift in perspective.
It changes everything. The goal of this treatment shouldn't be just to induce sedation for staff convenience or to have a quiet unit. The goal should be to administer an agent that helps the patient regain behavioral control and safely participate in their own assessment and treatment. Sedation is often an unavoidable side effect of these drugs, sure, but it should never be the primary objective. If the only goal is to knock them out, that's where we cross the line into chemical restraint.
Okay, so when we start looking at prevalence, the sheer scale of this problem across the healthcare system becomes really clear. Although the data is, it's incredibly variable depending on the unit. Overall, in acute care settings, the average prevalence seems to be around 8.7% of hospitalized patients. That means they experience at least one restraint over a 30-day period. And of those, mechanical or physical restraints account for a little over half the cases, about 55.0%. But that 8.7% average, it really hides some shocking variability.
It really does. When you zero in on the intensive care unit, the numbers just jump significantly. And that reflects the acuity of the patient population. High rates of delirium, invasive devices, mechanical ventilation. The ICU prevalence ranges dramatically. We see documented rates of 0% in some highly protocolized European centers, which, by the way, suggests that eliminating physical restraints is an achievable ideal.
0%. That's incredible.
It is, but you contrast that with regions in North America where the rates can climb to over 75%.
75%. That is staggering.
It means 3 out of 4 critically ill patients are restrained at some point. About 39% of all ICU encounters typically involve physical restraint, especially in mechanically ventilated patients who are deemed at high risk for, self-extubation or pulling out a device.
So you've got this massive gulf between 0% and 75%, depending on geography and the local practice culture. And in stark contrast, on the general medical wards, where acuity is lower and patients are generally more lucid, you see much lower usage, something like 1.3% of non-ICU hospitalizations. So the problem is clearly concentrated in our most vulnerable, highest acuity populations.
And when you look at the cited justifications for these restraints, they're remarkably consistent across all settings. The single most common justification cited by nurses and physicians, accounting for a massive 43.8% of cases, is fall prevention.
Fall prevention.
Yes, other rationales include preventing self-harm, managing confusion or delirium, which is cited in about 20.4% of cases, and preventing interference with essential medical therapy, pulling out a central line or self-extubation.
And here's where it gets really interesting. This is where we hit that core philosophical paradox that should force every single one of us as clinicians to pause. While those are the stated rationales, the belief systems that are underpinning the action, the empirical evidence often suggests the exact opposite. We are intervening to protect the patient, but we may actually be increasing their risk. Descriptive studies actually report higher rates of the very events restraints are supposed to prevent.
That's the crux of the issue. When you restrain a patient to prevent self-extubation, for example, studies show that you are associated with more unplanned extubations, not fewer. The patient often struggles harder, their anxiety increases, and they become more agitated. Restraints are also associated with more device removal overall, increased agitation, and counterintuitively a longer ICU length of stay. The data suggests that restraint is frequently an ineffective or even a counterproductive safety measure. It just compounds the risk and prolongs the recovery process. It really suggests that the action is driven more by clinician anxiety or systemic limitations, not robust evidence.
That finding is so critical. And it means we absolutely have to meticulously classify and understand the tools we are using before we even think about touching them. Let's dedicate some time now to digging into the detailed taxonomy of these interventions. Let's start with the physical devices and how they're classified in the literature.
The list is unfortunately pretty detailed because it covers every way we might restrict a patient's movement. We can start with limb restraints, which are probably the most common. These are the wrist and ankle restraints, whether they're soft cloth or the harder leather devices. They're designed primarily to restrict extremity movement. There are also specialized devices like wrist-to-waist restraints that allow for some limited range of motion, maybe for repositioning, but they prevent the patient from extending their arms to harm staff or interfere with tubes.
Then you have the trunk or torso restraints?
Right. These include vests and belts applied across the chest or the waist. These are often used with confused patients to prevent them from rising unassisted from a bed or chair. Ostensibly for fall prevention, which we've already noted is a pretty dubious justification. We also talked about bed rails, which become a restraint when used restrictively, and we also see the use of enclosure beds or safety net beds, although the evidence for their superiority over just a simple low-height bed is quite limited.
And we can't forget about the human intervention side of this.
No, we can't. Physical holds are classified as a physical restraint. This is staff-to-patient bodily contact used specifically to restrain the patient, maybe to administer medication involuntarily, or to hold them still for an urgent procedure when all other de-escalation methods have failed. Even though there's no mechanical device involved, it falls under the same regulatory umbrella and requires the same assessment and monitoring.
Okay, moving to the pharmacologic side, what we've agreed to call the pharmacological treatment of agitation. Which agents are typically employed, and what is it that makes them chemical restraints?
The medication classes are varied, and they really depend on the underlying etiology and the severity of the agitation. The most common category is antipsychotics. This includes first-generation agents like haloperidol, droperidol, and chlorpromazine. These are rapid-acting, but they carry significant risks, particularly QTc prolongation and extrapyramidal symptoms.
And the second-generation agents.
Right. We also use second-generation or atypical antipsychotics, things like olanzapine, risperidone, and quetiapine. They generally have a better side effect profile, but they might take a little longer to act.
And for those moments of just severe, acute behavioral disturbance, especially when rapid control is absolutely paramount, which agents are preferred?
For managing a truly severe acute behavioral disturbance in an emergency setting, like an agitated patient who's in immediate danger, current guidelines often recommend droperidol or olanzapine. They're recommended as first-line parenteral agents because of their rapid onset and reliability. But it's so important to remember that the goal is not oblivion. The goal is behavioral control and safety.
And what about the benzodiazepines? They seem to be the default choice in so many institutions, but the guidance seems increasingly cautious about just using them for everything.
The guidance is definitely cautious, and for very good reason. Benzodiazepines like midazolam, lorazepam, diazepam, they are powerful sedatives. However, current recommendations really emphasize reserving them for specific indications. Primarily known alcohol or benzodiazepine withdrawal, or certain types of catatonia where they are actually a necessary part of the treatment. Using them for routine agitation, especially in elderly patients or those with delirium, can often just worsen cognitive function, prolong the delirium, and increase fall risk. You're just masking the underlying problem and complicating the assessment.
And for those extremely dangerous or refractory situations, our sources do note the potential use of agents like ketamine for rescue therapy. But again, this brings us back to that key distinction we mentioned earlier, the one between genuine therapeutic sedation and chemical restraint. It's just fundamental to ethical practice and patient outcome.
Absolutely. We need to be able to articulate the difference clearly, and it boils down entirely to purpose. Therapeutic sedation is used specifically to treat or manage an underlying medical condition. This includes scenarios like managing status epilepticus, reducing intracranial hypertension, facilitating safe mechanical ventilation, or providing complex, intense pain management that requires deep sedation. The indication is purely clinical treatment, and the level of sedation is often titrated based on RSS or a similar scale to meet that specific clinical need.
And chemical restraint, conversely, is used solely to control behavior or restrict movement, regardless of the patient's underlying medical treatment needs.
Precisely. Inappropriate pharmacological treatment. The ultimate goal is to calm the patient so they can safely participate in assessment and treatment and regain behavioral control, to allow them to cooperate with necessary care. If we're using a drug primarily to achieve compliance or immobility, we're in the realm of restraint, and all the ethical and regulatory requirements that follow must be met. This is why the systematic approach to managing pain, agitation, and delirium, like the ICU algorithms, they prioritize pain control and delirium management, and they reserve deep sedation only for specific, necessary clinical indications.
Before we delve deeper into the indications for restraints, let's quickly look at the immediate alternatives. Because the pathway to restraint must necessarily involve the failure of less restrictive means. What are the immediate environmental and technological alternatives that can reduce risk without resorting to restraint?
These are often low-tech but highly effective solutions. We should immediately be implementing measures that reduce risk, bed exit alarms and pressure sensors that alert staff before patient is fully out of bed, low-height beds with floor padding to mitigate injury risk if a fall does occur, and just ensuring the environment is physically safe, removing hazards that could cause harm.
And perhaps the most effective, though often resource-intensive intervention, is the staffing intervention, one-to-one observation, or sitters. But we need to be clear, this can't just be a warm body in the room. These individuals must be staff trained specifically in de-escalation techniques. They have to be capable of proactive intervention, reassurance, and redirection, not just passive observers waiting for a crisis.
And other environmental modifications are critical as first-line interventions. These include reducing stimulation, moving the patient to a quiet room, utilizing sensory rooms, offering calming activities like music, or simply removing unnecessary or frightening medical equipment that the patient might attempt to pull out due to their confusion or agitation. Focusing on sensory regulation can prevent the need for chemical or physical intervention entirely.
Okay, so when we move into the actual application of restraints, we have to recognize, based on everything we've just discussed, that the indications are extraordinarily limited and tightly regulated by federal standards. This is where we lay down the absolute rules.
The core legal mandate, and this is based on Centers for Medicare and Medicaid Services, CMS regulations, is non-negotiable. It provides no wiggle room. Restraints can legally only be used in an emergency safety situation to prevent immediate harm to self, staff, or others. And critically, they can only be applied after staff have documented that all lesser restrictive interventions have been attempted and have failed, or are clearly inappropriate given the immediacy of the danger.
The corollary of that mandate needs to be stressed, because this is where practice so often diverges from compliance. Restraints must never, under any circumstance, be used for convenience to compensate for staffing shortages, as a form of coercion, discipline, or retaliation against a difficult patient. That is explicitly forbidden. If a hospital is found to be using restraints for non-safety reasons, they face immediate and severe sanctions.
And despite this clear legal mandate, let's just revisit that prevalence data for a second. We noted that 43.8% of cases cite fall prevention and 20.4% cite general confusion. This indicates a widespread disconnect. If we are using restraints for fall prevention, we are violating the immediate harm rule, and we're flying in the face of the evidence that shows restraints are associated with higher rates of unplanned extubations and device removal. The clinician's instinct to protect is actually leading to a paradoxical increase in risk.
That cognitive dissonance is just immense. We're taught to secure the patient, yet the evidence says securing them makes them struggle more and thus makes them less secure. This is why the required hierarchy of interventions, the least restrictive means principle, is the single most important framework for decision-making in an acute behavioral crisis.
This hierarchy outlines the necessary sequence that must be followed and documented before physical or forced chemical restraint is even considered. It demands a systematic, step-by-step approach.
The first and most critical step is verbal de-escalation. And this is a skill set, not just a casual attempt at talking them down. Our sources indicate that high-quality, professional verbal de-escalation is effective for the vast majority of patients, often within 5 minutes. Staff have to be trained to use a calm demeanor, simple language, non-threatening body posture, and to validate the patient's feelings even while they're setting limits.
And if verbal de-escalation isn't working or the risk is escalating, we move to non-pharmacologic environmental interventions. This means offering comfort measures, quiet rooms, calming music, sensory items like weighted blankets, or even simple redirection toward a familiar task or object. These are measures taken to reduce external stimuli that may be fueling the agitation.
Only when those efforts fail do we move to medication. And even then, we start with the least restrictive pharmacologic means, voluntary oral medications. This includes things like rapid dissolving formulations that can be offered and accepted by the patient, which preserves some level of their autonomy and choice.
If the patient refuses, or if their condition prevents them from taking oral medication, for example, they're combative and spitting the pills out, and the danger is acute and escalating.
No.
Then we move to involuntary intramuscular medications as the last resort pharmacologic intervention. This is administered only in acutely dangerous situations where the immediate risk outweighs the infringement on their autonomy.
And only at the very bottom of this hierarchy, if imminent danger persists, and all previous measures have failed or been deemed inappropriate due to the severity of the situation, are physical restraints or seclusion justified? The clinical challenge here is profound. Restraints must be used after less restrictive means have demonstrably failed, but before harm occurs. This requires highly trained, instantaneous, and accountable staff judgment in a rapidly unfolding crisis, and that judgment must be documented thoroughly.
From an ethical standpoint, the use of restraint can only be justifiable if 3 core conditions are met. First, there must be informed consent from the patient or a valid legal exception to consent, like the emergency situation justifying the prevention of harm. Second, the intervention must be medically appropriate for the patient's clinical status. And third, and most importantly, it must be the least liberty-restricting means available to achieve the intended safety benefit.
We mentioned documentation earlier, and this is where the system so frequently breaks down. There's a huge compliance gap. Our sources show that in acute care settings, regular documented evaluation, which is a mandatory procedural requirement, was present in only 42.9% of restraint cases. That means in over half the cases, the necessary follow-up checks, the rationale updates, and the physician evaluations required by regulation were not properly recorded. That just highlights a systemic failure in accountability.
Moving on to the devastating consequences, we have to emphasize that restraints carry substantial morbidity and mortality. This is not a benign intervention. It makes rigorous and mandatory risk assessment crucial before application, not just afterward. The decision to apply restraints is a decision to potentially expose the patient to severe harm.
So what are the primary relative contraindications we should be acutely aware of when we're considering whether to restrain a patient?
Well, we must exercise extreme caution with any patient presenting with significant respiratory compromise, like severe COPD or advanced heart failure. That's because restraints can further impede chest wall expansion or increase the risk of aspiration, especially if they struggle while positioned supine. Furthermore, patients with severe peripheral vascular disease or those with known thrombotic risk factors are relative contraindications because immobilization drastically elevates the risk of deep vein thrombosis.
And given the high prevalence of psychiatric comorbidity and underlying trauma in our patient population, recognizing that the use of restraints can lead to profound re-traumatization is essential. This isn't just a psychological risk, it's a medical contraindication if alternative methods are available.
Focusing now on the severe physical complications, the iatrogenic harm, the data is absolutely sobering. It should be a wake-up call for any clinician who relies on this intervention. Thromboembolism is a major killer. One study on psychiatric inpatients showed that those subjected to physical restraint had a staggering 6.0-fold increased risk of deep vein thrombosis and consequently pulmonary embolism. And that was even when standard prophylactic measures were in place. Immobility kills, and restraints enforce immobility.
The risk of infection is also dramatically elevated. Physical restraint is associated with a 4.1-fold increased risk of aspiration pneumonia compared to non-restrained patients. When a patient is struggling against restraints, they are often in a compromised position, which increases gastric pressure and the likelihood of aspirating stomach contents. And that can lead to a potentially fatal pneumonia. This heightened aspiration risk is a clear and immediate danger.
Then you have the mechanical and systemic injuries. This includes fractures, particularly if the patient attempts violent maneuvers to escape. Nerve compression, leading to long-term neurological damage, and ischemia from struggling against straps that may be too tight, cutting off circulation. Systemically, we see complications like rhabdomyolysis from prolonged, intense muscle struggle and breakdown, which results in acute kidney injury. We also see pressure injuries, bed sores developing rapidly due to immobility, and incontinence caused by the inability to access toileting facilities or call for help.
And tragically, we have to acknowledge the ultimate risk, fatalities. While rare, case reports describe deaths from positional asphyxiation, strangulation, or just the inability to breathe. Cardiac arrest precipitated by the extreme stress of the struggle, and of course, massive pulmonary embolism. The Joint Commission views any restraint-related death as a sentinel event, which just underscores the severity of this risk in the regulatory landscape.
The physical risks demand our immediate clinical attention, but the profound psychological harms can carry a lifelong cost for the patient. The incidence of post-traumatic stress disorder, or PTSD, following a restraint event is shockingly high. It ranges from 25% to 47% in the literature. Furthermore, physical restraint use has been directly correlated with increased PTSD symptoms in ICU survivors, adding a layer of psychological burden on top of their critical illness.
Acute distress during the event is marked by intense feelings of helplessness, tension, fear, and rage. Patients who have been physically restrained report significantly higher rates of perceived coercion compared to those placed in seclusion, even when the goal was their safety. This results in a tremendous loss of dignity, a severe erosion of trust in the healthcare system, and it can dramatically exacerbate underlying psychiatric conditions. This data just compels us to utilize a trauma-informed approach in all our care delivery, particularly when we're discussing de-escalation.
And the clinical costs extend far beyond the immediate event or the psychological toll. Restraints are linked to an increased morbidity association. They are significantly associated with an increased risk for developing delirium or disorientation, carrying a staggering odds ratio of 11.54.
An OR of 11.54 for delirium. That means we are actively creating or propagating the very brain dysfunction we are often attempting to manage. That just flips the entire risk-benefit calculation on its head. Additionally, restraints are linked to a longer duration of mechanical ventilation with a mean difference of 3.35 days, which extends the patient's time in the ICU and requires increased use of benzodiazepines, opioids, and antipsychotics, which only further compounds the risk of ongoing delirium. The picture is just so clear. Restraint is a net negative for patient recovery.
All of this data just reinforces the absolute imperative that before any restraint is applied, physical or chemical, we must have a rigorous, documented assessment protocol in place. We have to identify and manage every possible reversible cause of agitation. We cannot assume the patient is just confused or just difficult.
This systematic evaluation is mandatory and it's non-negotiable. Before a hand is laid on the patient for restraint, staff must conduct a comprehensive assessment to identify contributors to agitation. This process is often streamlined using the etiology checklist, which can utilize a mnemonic like delirium to make sure no stone is left unturned.
Yeah, let's break down that delirium approach. We can start with delirium itself, noting that it is the most common manifestation of acute brain dysfunction in hospitalized patients. Then we move to the reversible physical causes. The I stands for infections. We are rigorously checking for things like UTIs or a subtle developing pneumonia that might present atypically in an elderly or confused patient.
The first M in delirium stands for medications, and this requires a thorough review of everything, including newly started drugs, anticholinergic agents, or any new psychoactive agents that may have a paradoxical effect. And the second M is for metabolic. We're looking for electrolyte disturbances, severe hypoglycemia, or uremia.
Next is hypoxia, or any form of respiratory compromise that's causing acute anxiety or confusion. The P is for pain control. Untreated pain is a massive, often overlooked contributor to agitation and is completely reversible. And finally, the W is for withdrawal syndromes from alcohol, benzodiazepines, or other substances. This systematic checklist prevents us from just jumping straight to the easiest solution, sedation or restraint.
And the required diagnostic workup to address this checklist must include some routine tests, a complete blood count, electrolytes, BUN, and creatinine. And depending on the presentation, we have to consider additional tests like toxicology screens, cultures of blood, urine, sputum, imaging like a chest X-ray or CT of the head, or even a lumbar puncture if meningitis is a possibility. A thorough medication reconciliation, including non-prescription drugs, supplements, and an accurate alcohol use history, is essential.
And beyond the physical causes, the cognitive incapacity assessment is non-negotiable. We have to use validated screening tools like the confusion assessment method for the ICU, the CAM-ICU, and the intensive care delirium screening checklist, or ICDSC, to screen for delirium. It's crucial to note that delirium symptoms wax and wane. That means these tools must be used frequently and systematically, not just once upon admission.
We also need to be able to distinguish acute delirium from chronic conditions like dementia. We can use tools like the 6-item cognitive impairment test or 6-CIT, which helps reduce the probability of misattributing agitation to chronic cognitive impairment when it's actually an acute, reversible process.
Furthermore, staff must assess for known risk factors for developing delirium, things like decreased vision or hearing, severe underlying illness, dehydration, or malnutrition. The literature is very clear. The presence of 3 to 4 of these risk factors increases the risk of inpatient delirium by more than 9-fold. Identifying these patients allows us to implement preventative non-pharmacologic interventions immediately.
This level of comprehensive assessment clearly requires multidisciplinary involvement. This cannot be the sole domain of the bedside nurse or the consulting physician. Team-based approaches have demonstrated remarkable success in reducing restraint use because they distribute the cognitive load and leverage different areas of expertise.
A prime example of that is the geriatric nurse practitioner-led co-care CI model. This involved a specialized consultation focused entirely on the care of cognitively impaired elders. The results were astounding. They showed a significant reduction in physical restraint use, dropping from 4.3% to a negligible 0.7%. And chemical restraint use fell from 7.6% to 2.3%. This success just underscores the need for clear communication, shared decision support algorithms, and a team culture that prioritizes non-pharmacologic solutions first.
Let's dedicate some substantial time now to the evidence-based alternatives because ultimately, this is where the solution lies. Our sources are absolutely clear. Non-pharmacologic interventions are the foundation of agitation and delirium management. And they are, in fact, the most effective strategy for prevention, leading to a documented 43% to 57% reduction in delirium incidence. Why would we ever reach for a chemical restraint if a simple environmental change is 57% effective?
Exactly. The components of these successful programs are often remarkably simple, relying on consistent human and environmental interventions. Reorientation and cognitive stimulation are vital. This means frequent reorientation to time, place, and person, utilizing familiar objects from home like photographs or a blanket, and ensuring consistent staff assignments so the patient isn't bombarded by new faces every shift. Consistent human connection reduces anxiety.
Then there's optimizing sleep hygiene. This means avoiding all unnecessary procedures during documented sleep hours. It means minimizing noise and alarms in the unit, a major source of agitation, ensuring adequate lighting during the day to help anchor the patient to the proper cycle, and encouraging relaxation techniques like music or massage at bedtime. Optimizing that natural sleep-wake cycle is critical to brain function.
And, of course, aggressive pain control. We have to prioritize scheduled around-the-clock pain medication using the lowest effective dose and leaning heavily on non-opioid strategies like round-the-clock acetaminophen. This reduces our reliance on opioids and other sedating agents which contribute to delirium. Untreated pain is a verifiable major contributor to agitation.
And we cannot overstate the importance of the human element. family presence. Family engagement, often designated as the F in modern critical care bundles, is critical for emotional support, for calming, and for reorientation. Having a familiar face, a familiar voice, a familiar touch, it's a powerful non-pharmacologic calming mechanism, often more effective than any drug we can administer.
In the intensive care unit, this management philosophy is codified into one of the most important multi-component approaches in critical care today, the ABCDEF bundle. This approach is specifically designed to manage critically ill patients who are simultaneously experiencing pain, agitation, and delirium while minimizing deep sedation.
Let's detail the components of this vital protocol, because it represents the gold standard for critical care today. A is foremost. Assess and manage pain using validated tools and scheduled medications. B stands for both spontaneous awakening trials, SAT, and spontaneous breathing trials, SBT, to avoid deep, prolonged sedation and get the patient off the ventilator sooner. And SAT means pausing sedation daily to check if the patient can follow commands, ensuring we are not over-sedating them. And C stands for choice of analgesia and sedation, prioritizing non-benzodiazepines whenever possible for sedation management.
The D is for delirium assessment, prevention, and management, using tools like the CAM-ICU repeatedly throughout the day. E is for early mobility and exercise. This is perhaps the hardest part logistically in the ICU, getting an intubated patient up and moving, maybe even walking with the ventilator, but it drastically reduces delirium and deconditioning. And finally, F is for family engagement and empowerment, utilizing that human connection we just discussed.
The results of consistent adherence to this bundle are unequivocal. Data shows a clear dose-response relationship. The greater the compliance with the ABCDEF bundle components, the better the outcomes. That includes improved survival, significantly reduced delirium incidence, lower institutional costs, and a decreased rate of discharge to a nursing home versus home.
The systemic programs are key to sustained success, proving that staff training and institutional commitment can overcome the barriers. The Hospital Elder Life Program, or HELP, is a fantastic model, specifically focused on prevention. A meta-analysis of HELP-like interventions showed they significantly reduced delirium incidence by an odds ratio of 0.47, and importantly, they also reduced in-hospital falls by an odds ratio of 0.38. This directly refutes the common justification for restraints fall prevention. Non-pharmacologic prevention works better than restrictive measures.
And underlying all of these models is the mandatory skill set of de-escalation and training. Verbal de-escalation training should be mandatory for all staff who interact with patients, whether in the ICU, the ED, or on the general floor. Its effectiveness, as we noted, is high. It works for the majority of patients within 5 minutes if it's applied correctly. This involves utilizing a calm demeanor, simple, concise language, and always offering choices to the patient, which helps them maintain some sliver of autonomy and control in a frightening situation.
All of this evidence-based practice is set against a backdrop of tight legal, ethical, and procedural compliance standards that we absolutely must adhere to. The penalties for non-compliance are severe, yet the practice gap persists.
Starting with the legal mandates from CMS and the Joint Commission, TJC, the time-limited orders are extremely specific and absolute based on age. Orders for physical or seclusion restraints are limited to 1 hour for children younger than age 9, 2 hours for ages 9 to 17, and a maximum of 4 hours for adults aged 18 and older. This means that after 4 hours for an adult, the entire process must be restarted with a new face-to-face evaluation and a new order. It is not a simple renewal.
And that face-to-face evaluation is perhaps the most difficult mandate to meet logistically. Within 1 hour of the initiation of restraint, there must be a face-to-face evaluation of the patient by a physician, a licensed independent practitioner, or a specially trained registered nurse or physician assistant. In a large, busy, or remote hospital setting, getting that provider to the bedside within 60 minutes requires tremendous logistical coordination. But it is necessary to ensure rapid clinical and legal oversight.
The patient can't just be forgotten once they're restrained. Continuous monitoring is mandatory and it's resource-intensive. Restrained patients require checks for their physical status, including pulse, blood pressure, and range of motion, literally every 15 minutes. This intensive monitoring is necessary because, as we discussed, the risks are immediate. Nerve compression, compartment syndrome, and vascular compromise can occur very quickly if the restraints are improperly applied or if the patient struggles continuously.
This rigorous regulation highlights the significant ethical framework we operate within. The tension is palpable. We are actively infringing on the ethical principle of autonomy, the patient's liberty of movement, and this is only justified if it fulfills the higher values of beneficence and non-maleficence. That is, acting in the patient's best interest and minimizing harm. The restraint must be the only remaining viable option to prevent that harm.
The concept of autonomy, even in crisis, can be partially preserved through tools like Psychiatric Advance Directives or PADs. These are documents created when the patient has capacity that allow them to state their preferences in advance regarding medications they prefer or refuse. They can designate specific supporters to be involved in the crisis or state a preference between seclusion versus physical restraint. These directives must be honored to the extent clinically safe, preserving the patient's voice during a moment of profound loss of control.
We also need to consider the principle of justice. We have to be vigilant about monitoring institutional data to prevent racial and ethnic disparities in restraint use. The literature shows that structural factors and implicit bias can sometimes contribute to the disproportionate application of restraints in historically marginalized populations. Justice demands that we ensure the application criteria are applied equally, regardless of patient demographics.
Let's revisit the documentation gaps because they demonstrate a massive problem in procedural compliance. We reemphasize that documentation of the use, the rationale, and the regular evaluation was absent in over half of acute care restraint cases. This is not just administrative paperwork. The documentation requirements, justifying that the least restrictive means failed, logging the 15-minute checks, these are fundamental mechanisms of safety and quality control. If we don't document it, we can't prove the intervention was necessary or safe.
The final procedural layer is ensuring safe application and removal procedures are followed precisely. If restraints are absolutely necessary, they must be applied with the minimum possible risk.
Application must only be performed by trained staff using standard-approved devices. Staff have to ensure proper fitting, like using a protective collar or padding for skin integrity, and ensuring neurovascular safety. Critically, each limb has to be secured to the stable bed frame, not to the bed rail, to prevent injury if the rail is accidentally lowered. And the straps should be secure enough to prevent escape, but never so tight that they impair circulation.
And those mandatory 15-minute checks, which are what make continuous monitoring so intense, they must specifically include checking for pulse, blood pressure, and range of motion distal to the restraints. Staff must continuously monitor for skin integrity, ensuring no pressure injuries are developing, and they have to address basic human needs like hydration and elimination. The ongoing psychological status is just as important. Staff must look for signs of increased agitation or escalating fear.
We've covered the age-specific limits for the time-limited orders, but it's worth emphasizing the need for frequent reassessment. Licensed independent practitioners have to perform regular in-person reevaluations every 4 hours for adults and more frequently for younger patients to ensure the continued necessity of the restraint. The moment the criteria for restraint are no longer met, the restraint must be removed.
And that leads us to the goal: early removal. Restraints must be discontinued at the earliest possible time. The criteria for removal are straightforward. The patient has regained behavioral control, the immediate risk of harm has fully resolved, or less restrictive interventions, such as one-to-one observation or new oral medication, are now effective.
The procedure for removal should be planned and team-based. The decision should be based on the team leader's assessment, whether to remove restraints one limb at a time or all at once based on the predicted response of the patient. If the patient manages to remove them independently, they must be immediately reassessed before any reapplication is considered, viewing the self-removal as a critical event requiring a clinical review.
And finally, we have to complete the loop with post-event care. When the crisis is over, the care is not. Mandatory steps include staff debriefing to review the event, assess team performance, and identify areas for prevention improvement. Crucially, there must be patient follow-up discussions to address the patient's experience of trauma, acknowledge their distress, and develop safety and crisis prevention plans together for any future episodes. This step is essential for restoring trust and dignity.
To synthesize this immensely complex discussion, the data strongly suggests that restraint minimization is not just an ethical ideal, but a clinical imperative. Restraints are not the effective safety measures they are often perceived to be, and they carry profound risks of physical injury, including severe issues like aspiration and thromboembolism, and long-term psychological damage, specifically PTSD. The very definition of the practice is paradoxical.
We must encourage our peers to fundamentally change their approach. The evidence demands that we move beyond using convenience or staffing shortages as primary justifications. The first line of defense against agitation and delirium must be the rigorous implementation of multidisciplinary, non-pharmacologic bundles like the ABCD-EVE and HLLP models, because these interventions are demonstrably safer, more effective, and lead to better overall patient outcomes than resorting to mechanical or chemical containment.
And this leaves us with a provocative final thought for you to consider and perhaps challenge the leadership in your own institutions. The experience of Pennsylvania state hospitals demonstrated nearly 10 years of successful cessation of seclusion and restraint use entirely through continuous adherence to evidence-based, trauma-informed strategies. If elimination, not just minimization, but elimination is possible in psychiatric settings where agitation is often the core diagnosis, what does that imply about the persistent necessity of restraints in general medical and ICU settings today? And how much regulatory and financial oversight should be mandated to aggressively bridge this persistent and frankly dangerous practice gap?